welcome all the speakers, Dr. Kailash, Dr. Sharma, Dr. Bhubadi, Dr. Shivaram Kannan, Dr. Chandrasekhar is there, no? Dr.
Yes.
Chandrasekhar, Dr. Nitin, our webinar coordinators, Nitin and Soumya. Now, I will introduce the first speaker, Dr. Sharma. You all know Dr. Sharma. I think there's no introduction is needed. Anyway, it is my duty. He is Emeritus Professor of Cardiology, Rajiv Gandhi Institute of Medical Sciences, Srikakulam, Andhra Pradesh. Adjunct Professor, Tamil Nadu, Dr. NGR Medical University, Chennai. Visiting Professor, GEMS College, Srikakulam. Honorary National Professor of Medicine, IMPAI, CGP. Ex-Secretary, American College of Physicians, India Chapter. Adjunct Faculty, JSS Medical University, Mysore. MRCP Online Faculty, Taxila, American University. Presently, he is Consultant Physician in Internal Medicine, Manipal Hospitals, Whitefield, Bangalore. He did his MBBS from Andhra Medical College, MD from Andhra Medical College, and MSc McMaster University, Hamilton, Ontario, Canada. He has various fellowships to his credit: Fellow of the International Medical Sciences Academy, Fellow of the College of General Practitioners, Fellow of the Royal College of Physicians and Surgeons, Fellow of the American College of Chest Physicians, Fellow of the Indian College of Physicians, Fellow of the American College of Physicians, Fellow of the Royal College of Physicians, Fellow of the IMPAI Academy of Medical Specialties. He has undergone various special trainings in various subjects. To name some: diabetes, hypertension, HIV, community medicine, clinical immunology, etc. He has outstanding teaching skills. He has his own CME group with more than 200 doctors and had delivered 250 plus CME talks so far. He had conducted more than 15 medical workshops in various conferences and presented an equal number of papers in multiple conferences. He had delivered innumerable lectures in many universities, colleges, conferences throughout India and abroad. He has got a lot of honors and awards to his credit. He is service-minded, organizes free medical camps, helps orphanage and old age homes, etc. He has special interest in religious and philosophical literature and poetry and regularly presents spiritual talks too. To conclude, he is a multifaceted personality. Over to you, sir. Thank you. I welcome all the speakers, Dr. Kailash, Dr. Sharma, Dr. Bhubadi, Dr. Shivaram Kannan, Dr. Chandrasekhar is there, no? Dr.
Yes.
Chandrasekhar, Dr. Nitin, our webinar coordinators, Nitin and Soumya. Welcome to everyone. We'll start the meeting with IMPAI prayer and physician's prayer. IMPAI prayer. May everybody be happy. May every one of us see to it that nobody suffers from any pain or sorrow. I do not ask for crown nor I wish to be in heaven or reborn. I only want to alleviate the suffering of those people who are burning in fire of sorrow. Physician prayer. Dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift must come from thee, I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart, give singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child I rely upon thee. Now, I will introduce the first speaker, Dr. Sharma. You all know Dr. Sharma. I think there's no introduction is needed. Anyway, it is my duty. He is Emeritus Professor of Cardiology, Rajiv Gandhi Institute of Medical Sciences, Srikakulam, Andhra Pradesh. Adjunct Professor, Tamil Nadu, Dr. NGR Medical University, Chennai. Visiting Professor, GEMS College, Srikakulam. Honorary National Professor of Medicine, IMPAI, CGP. Ex-Secretary, American College of Physicians, India Chapter. Adjunct Faculty, JSS Medical University, Mysore. MRCP Online Faculty, Taxila, American University. Presently, he is Consultant Physician in Internal Medicine, Manipal Hospitals, Whitefield, Bangalore. He did his MBBS from Andhra Medical College, MD from Andhra Medical College, and MSc McMaster University, Hamilton, Ontario, Canada. He has various fellowships to his credit: Fellow of the International Medical Sciences Academy, Fellow of the College of General Practitioners, Fellow of the Royal College of Physicians and Surgeons, Fellow of the American College of Chest Physicians, Fellow of the Indian College of Physicians, Fellow of the American College of Physicians, Fellow of the Royal College of Physicians, Fellow of the IMPAI Academy of Medical Specialties. He has undergone various special trainings in various subjects. To name some: diabetes, hypertension, HIV, community medicine, clinical immunology, etc. He has outstanding teaching skills. He has his own CME group with more than 200 doctors and had delivered 250 plus CME talks so far. He had conducted more than 15 medical workshops in various conferences and presented an equal number of papers in multiple conferences. He had delivered innumerable lectures in many universities, colleges, conferences throughout India and abroad. He has got a lot of honors and awards to his credit. He is service-minded, organizes free medical camps, helps orphanage and old age homes, etc. He has special interest in religious and philosophical literature and poetry and regularly presents spiritual talks too. To conclude, he is a multifaceted personality. Over to you, sir. Thank you.
Thank you very much. I request all the participants to mute their videos so that my sharing will be better. And please mute your videos as well as the audios. And once I finish, again, we can come back on the video and so she has read a host of things about me. Thanks to Dr. Girija Ramamurthy for the nice kind introduction and sweet words. But unfortunately or fortunately, we should not be carried away by whatever titles that are there next to our name. Only thing is what we are able to do and how much we are able to contribute to the world at large and to the medical community in particular is very important. So let us see the approach to Vertigo. Humble obeisance to all my teachers who made my life so well carved out and then so happy now, all because of the teachers, both medical and non-medical, who made me today. So, idam namama, even this is not mine. With that approach, we are starting. You understand? All of you, please mute your microphones. I don't want even a single pin drop disturbance. Please. There are 6 senses. You may be wondering what is the 6th sense. All the time you will be calling, he has a 6th sense. What is the 6th sense? The 6th sense here is the equilibrium. Vision, hearing, touch, pain, taste, smell, you all know. We have a 6th sense, so-called 6th sense called the equilibrium. Okay, and that equilibrium strength or the balance is the one which we are discussing today. Now you see this is a very beautiful diagram. All of you are familiar with that. There are 2 components. The blue component there is the cochlear component and the orange component is the vestibular component. Okay, and then we have what is called the vestibular component. We are interested today. It has got the 3 semicircular canals, the saccule and the utricle and the vestibular nerve there, and the cochlear nerve here, the blue colored one, and both together join they are called the 8th nerve, and of course they join the facial nerve for the onward traversing into the brain. So this is the basic understanding. There is an oval window there. There is also a round window. These are the cochlear turns here. This is about the labyrinth and the semicircular canals, very gross way. So let us go a little focus into the semicircular canals. We have a superior semicircular canal. We have a lateral semicircular canal. We have a posterior semicircular canal. These 3 are arranged at right angles so that the information for the position of the brain, position of the head is known to the brain all the time. These detect the angular moment as well as the vertical and lateral moment, and that is transmitted. There is a fluid inside this that is called the endolymphatic fluid, and this is the saccule and the utricle there, and they are connected. These are connected to the vestibular nerve. There are some loose particles there. What are those loose particles? They are not disease. I'll show you shortly. So here, this is called the vestibular apparatus. So many things are there that it's called vestibular apparatus. Likewise, we have got the hearing apparatus, which we are not going to deal today. So vestibular apparatus has got the otolithic apparatus. Otolithic apparatus has the utricle and the saccule, which I showed you, and contain the small particles like thing called the otoconia. These otoconia are calcium carbonate microcrystals. So calcium carbonate microcrystals are there. These otoconia are here on the top of the cupola, and these are the hair cells there. Whenever there is a movement of the head, the otoconia are like pebbles moving in a tube. They move around. So much so the underlying cupola is moved, and this bends the hair cells, and these hair cells are this bends the heads of the hair cells, and the impulses are carried to the vestibule, and through the vestibular nerve it goes into the brain. And this is maximum for the linear movement. Then there are 3 semicircular canals which they do not normally contain the otoliths, but they have endolymph and the cilia, and they register the velocity of the head movement, and also the angular movement is registered. And all these things, informations are fed onto the vestibular nerve, and which is carried on to vestibulo-ocular reflexes, vestibulo-ocular pathways, and vestibulospinal reflexes, vestibulospinal pathways. This is in nutshell what is going on about the vestibular apparatus. Now, if you see here, there are 5 different things connected to the vestibule directly or indirectly. So we have the first thing is most important vestibulo-ocular system, which is called the vestibulo-ocular reflex. This is the oculomotor muscles, and the eyes are connected to the vestibular system. Second thing is vestibulo-cerebellar, because cerebellum is the one which keeps the equilibrium, and so vestibulo-cerebellar. And finally we have, and thirdly we have the brainstem. To the medulla and the brainstem, there is vestibulo-bulbar there, and of course the spinal muscle, vestibulo-spinal reflexes, reflex arc, and vestibulo-spinal pathways also are there, and vestibulo-cortical projections. Of course, vestibule and cochlea are also interconnected, because hearing and balance are interconnected things. These are the intricate connections that we are having. There are microcomputers there. There are 3 semicircular canals of microcomputers which tell you about the position of the head in relation to the body, and also about the movement of the head, both angular, linear, and vertical. Now, the spatial orientation of our cells. See, man is a biped animal, right? So, unlike the other animals which are quadrupeds, they don't have much of balance problem. They are in a beautiful, perfect equilibrium. Whereas we are, in your physics, you would have learned that we are in a unstable equilibrium, because the center of gravity is much away from the base, and also it is in a very narrow area it has to fall. That is what is called the unstable equilibrium. But we are made stable. Of course, we are not stable mentally. Most of us, we have lots of problems understanding our mind and not able to negotiate the world well. For that, the separate talk on philosophy is required. But the stability we are talking about is the physical stability here, and it has got 3 important areas. One is the eye, the other is the vestibule, the third is the sensory inputs from your peripheral nerves. So these 3 together will manage how we walk, how we stand, without any difficulty for us to negotiate various movements that we do during our day-to-day life. All these have got, of course, direct projections into the brainstem and into the cerebral and cerebellar cortex. Now, there are 3 important things that come to you when a patient comes into your chamber with, "Sir, I have giddiness or dizziness." First thing is, it is vertigo. Is it syncope? Is it gait ataxia? These are 3 interrelated subjects. And if Kailash and our group members agree, we might do gait ataxia as well as syncope also as separate lectures, but we will try to concentrate mostly on the vertigo as of now. Okay. Now, the common thing is, patient do come with a subjective term called the dizziness. This is the word used in Western textbooks and Western patients, but our patients will say giddiness. Both are same. Giddiness or dizziness, interchangeably used. Sensation of movement, spinning, involving the revolving movement, and then swaying of the body, unsteadiness, as though being pushed to one side. 10% of the adults above 55 have vestibular problem. Is it sweet news? No. Because what is the percentage of population of hypertension above 55? Not 10%. But people who have vestibular problems, 10% of them, they do have vestibular problems. So it tells us that one has to be very careful as one ages. While they get up, they particularly in the dim light or during night time, and they have to see that they don't injure themselves. And that is the age where the bones are fragile. If they fall, that's it. We have a radial fracture or we have a hip fracture. You can imagine the status. Mild uneasiness to severe balance problems, all are there as far as we are these ones are concerned. Now, don't take these symptoms lightly. So we have to understand that the severity of the giddiness is not directly related to the severity of the disease inside the brain. For example, person may be extremely giddy for about 2 months or 3 months, not able to get up and walk, but it is only benign positional vertigo. Sometimes they have mild balance disturbance. Already there is an involvement of the cerebrum, or there is a tumor in the brain. So the symptoms are not directly proportional to the degree. So mismatch of the 3 systems of balance. What are the 3 systems? The ocular reflexes, the vestibular reflexes, and of course the peripheral sensory reflexes. So all of us would have experienced giddiness, particularly when we have unfamiliar head movements. What are unfamiliar head movements? Unfamiliar head movements means, for example, we are traveling in a ship. We all of us get giddiness and vomiting, or when we go on merry-go-rounds, or simply when we rotate ourselves, in the at home, just like this, children will be playing this rounding thing. Immediately after 5 or 6 rounds, we start feeling giddy. Why? Because the semicircular canals are so disturbed, they are not able to orient where the head is in relation to the body during these positions. They get impulses and they get confused. First time they think that they are lateral, anterior, forward, left, right, up, down. They are not able to comprehend, and then they will try to throw the person onto the ground, because at that time all the movements of the head cease and the system is restored to normal. So falling to the ground is a protective mechanism as far as the syncope or as far as the vestibular disturbance is concerned, but we can avoid the falls by knowing early. So these giant wheel rides, merry-go-round, seasickness, these are all physiological vertigo we do have, all of us. This is not pathological, but unusual head position. Sometimes you want to do some ceiling painting or fix some light on the ceiling or fix a fan by bending upwards like that, or looking from vertical, however, vertigo from height, from a great height like Eiffel Tower in Paris, trying to look down, or you have motion pictures and vertigo. Very fast moving pictures are going, you feel dizzy sometimes. This is also very common. Space sickness is also reported because of the zero gravity environment in the space. They do have the space sickness like sea sickness. Optical illusions by rapidly changing scenes. For example, if the train is going very fast, if you want to look at the very nearby object through the window, not farther objects like trees, if you look at the other track for continuously for 2-3 minutes, you feel dizzy. This is all because of the optical illusions. Pre-syncope or lightheadedness is different from vertigo, which we look at when we see the syncope one. Now, what are all the various causes? Every disease we require to know the etiological factors: autological, neurological, medical, psychological. Take it from me, 50% of the diseases which cause disturbance in the vestibular function are autological. These are also called peripheral. Autological, 50%, the peripheral computer or the peripheral organ is at fault. That's why it is called autological peripheral vertigo, 50%. Neurological causes, central vertigo. General vertigo is due to medical causes, of course psychological. Neurological, medical, psychological, one-third of the 50%, and the remaining 50% is autological. Now, there are asymmetric involvement and symmetric involvement. Asymmetric involvement we see in Meniere's disease and vestibular neuronitis. That is, one vestibular apparatus is more affected than the other. We have two computers, one on the right side, one on the left side. If both of them are symmetrically damaged, it is symmetric involvement. Asymmetric is one will be damaged, the other is normal. That is called asymmetric involvement. Symmetric involvement can occur due to systemic toxins like ototoxins, gentamicin and kanamycin, netilmycin, all these aminoglycosides, as well as furosemide, the very commonly used torsemide, furosemide in large doses for long term, and also quinine and certain other medications. We have a slide on the ototoxic drugs, we will see there. And also bilateral forms of vestibular neuronitis can also occur. Vestibular neuronitis is like any other neuronitis. Suppose there is neuronitis of the radial nerve. Like that, this is also a vestibular neuronitis. It is a viral infection or a bacterial infection of the vestibular neurons. Then there is what is called cross coupling. Cross coupling means this is what happens in benign paroxysmal positional vertigo. One vestibular apparatus is more damaged than the other, and they are not able to keep the balance in terms of understanding the position of the head in relation to the body. There could be also fistula. I'll show you what it is. There could be also superior canal dehiscence or SCD. I'll show you what it is. So these are other important things. Now, if you look at the inner ear apparatus, this is the cochlea here. These are the semicircular canals. They are all housed in a bony labyrinth there. In that bony labyrinth, they are protected from damage. So this is exactly what is called the leak at the perilymphatic leak occurs in the opening in the round window. This is the oval window where the incus malleus and step is there. No, the medullary ossicle. They go and impinge on for the hearing. Whereas this is the round window. If there is a membranous window there, if there is a small leak of the perilymph, it can come into the medullary cavity. This is called perilymph fistula, and that damages the vestibular balance there inside, the fluid balance. So there will be a vestibular problem. Likewise, there could be superior canal dehiscence. This is the superior canal. These are again housed in the bony labyrinth, but somehow the superior canal is more vulnerable for damage and it can open it itself up, and that is called the superior canal dehiscence. Now, coming to the neurologic vertigo, these are autologic things. Neurologic one is VBI, vestibulobasilar insufficiency. Most of you would know vestibulobasilar insufficiency. That is the blood vessel going into the back part of the brain. The basilar artery is there. The two vertebral arteries go up, they join to form the basilar artery. The basilar artery again goes forward and divides into the two posterior cerebral arteries. This is called the basilar circulation, and then there is a sort of compromise in the vestibular circulation. That is why it is called vestibulobasilar insufficiency, and it can also lead to stroke. Most common neurological cause of vertigo. So most common neurological vertigo. Migraine, 10% of the causes of central vertigo are due to migraine. Every patient of vertigo, we need to take the history related to migraine, treat the migraine, the vertigo goes. Multi-system disequilibrium can occur in the elderly, particularly due to the sensory deficiency. And one thing is, the moment the patient comes to our chamber, somebody says giddiness, immediately we know, no, take an X-ray of the cervical spine. One of the causes of vertigo, all right, but not the common cause of vertigo. And how does it cause, we will see shortly. And also there is low pressure CSF syndrome like post lumbar puncture or CSF leak due to CSF rhinorrhea, or any other causes can also occur. So we looked at the neurological causes and the vestibular causes, autological causes also. General medical causes, somebody is having anemia, let us say severe anemia, they will have definitely vertigo. High blood pressure. Another thing is patient to say, sir, உங்களுக்கு BP இருக்கான்னு. No sir, எனக்கு எப்பவுமே giddiness இல்லை sir, எனக்கு BP எப்படி இருக்கும் sir. They think that BP and giddiness are directly connected. Very few patients of hypertension have vertigo as the presenting symptom. They may have in very high hypertension states, but then only 5% of the people with hypertension do have real vertigo. Cardiac arrhythmias, syncope, and then also the orthostatic hypotension or postural hypotension are some of the common causes of cardiovascular disease. When I say postural hypotension, when we treat hypertension patients, we do put them on antihypertensive drugs. Some of them are notorious to cause vasodilatation, peripheral vasodilatation, and orthostatic hypotension. Notable among them are the alpha blockers and the calcium channel blockers in that order. Alpha blockers are the worst ones, which can cause postural hypotension or orthostatic hypotension. Hypoglycemia, of course, certainly can cause dizziness and giddiness. Insulin use, people who are on insulin, if the dose is mismatched, they can develop that. Medications, antihypertensives, I told you. Vasodilators also, for any reason we use, they can result in giddiness. Infections like pneumonia, UTI, acute suppurative otitis media, chronic medullary disease, all these can also produce. Of course, B12 deficiency for a long time, subacute combined degeneration of the spinal cord can produce ataxia and giddiness. Psychogenic causes, somatization disorders, panic disorders, GAD, generalized anxiety disorders, and depression are notorious to cause psychogenic type of giddiness. That is, they come with complaint of dizziness or giddiness, we evaluate and nothing can be found. If you look at the mental makeup of them, they have somatization disorder. They have some problem in the family or in the job or in whatever is the friend, lifestyle, life friend, that will somatize itself here as giddiness. They feel giddiness and then they sleep. No, I'm feeling dizzy. I'm not able to stand. Like Panic attacks also, they come and go. Panic attack, the typical example is the status of Arjuna in the Mahabharata, this Bhagavad Gita first chapter is a typical example of panic attack. GAD, generalized anxiety disorder, depression, these are also associated with psychogenic vertigo. Hyperventilation syndromes, people who hyperventilate, particularly the variant of anxiety, when they hyperventilate, what will happen? The carbon dioxide is washed out. And the giddiness is felt at that time point. Unknown causes, causes not identifiable are not worked up, are unknown causes. So we had autological causes, neurological causes, medical causes, psychological causes. Now, before you really pin down and say this patient has vertigo or not, you need to put forth these following questions to your patient. The first one is, do you feel unsteady while standing or walking? It could be ataxia, it could be vertigo also. Do you feel as if the room is spinning around you? This is called the objective vertigo. The objects are spinning. Do you feel as if you are moving when you are in standing or sitting position? This is called the subjective vertigo. Objective vertigo is generally a feature of intracranial disorders and general medical disorders. Subjective vertigo is generally a feature of the otological causes. Do you lose your balance and fall? At any time did you fall? Do you feel as if you are falling, as though you are about to fall? Do you feel as if you might faint? Some people sometimes call this as lightheadedness. Do you feel that your vision becomes blurred? This is another question you have to ask. Do you ever feel disoriented? Means loss of sense of time, place and identity. இப்போ எங்க இருக்கேன், என்ன பண்றேன், மணி என்னாச்சு, நீங்க யாரு? These are the disorientation questions. So you have to put forth these questions and the answers to them will decide whether a patient really has vertigo or whether he has got syncopal attack or whether he is ataxic or whether it is a pre-syncopal state. Now, one way of differentiating them is by the duration. How long the vertigo lasts? If the vertigo lasts for minutes, for seconds, எவ்வளோ நேரம் இருக்கும்ப்பா, 10 நிமிஷம், 10 செகண்ட், 20 செகண்ட் சார், ஒரு 1 மினிட்டுக்குள்ளேயே நான் நார்மல் ஆயிடுவேன், ஆனால் 1 மினிட் திடீர்னு தலை சுத்தும். That is benign positional paroxysmal vertigo. Okay, it is not minutes or hours or days, it is few seconds to maximum a minute or two. If it is lasting for 5 minutes, 10 minutes, it is VBI or transient ischemic attack. If it is for hours, associated with tinnitus, hearing loss, and then watering of the eyes, it is Meniere's disease. If it is days, it is vestibular neuronitis. If it is months, cervical spondylosis and cervical vertigo is the reason. If it is for years, it is ototoxins. This is one way as a clinician, I always try to determine what could be the etiology because the treatment is dependent on the etiology. Etiology and pathogenesis are the essential part of every disease. Then only we will be able to really understand the disease well and aim to rectify the problem. So otherwise, giddiness as such doesn't have any meaning unless we know these things. So remember these things: BPPV in seconds, VBI and TIA in minutes, Meniere's in hours, vestibular neuronitis in days, cervical vertigo in months, ototoxins for years. Now this is called vertigo sieve. Sieve na, you know, not jelly. So where you sieve your flour and remove the husk from that. Like that, you can sieve the patient symptoms into 3 types. Onset instantaneous, duration 30 to 60 seconds, associated with tinnitus. That is one group of patients. Onset acute, few minutes to hours, loss of hearing is associated. Onset is slow, days or months, CNS findings are there. Onset is paroxysmal, duration is continuous, cardiovascular disease is associated. So the first one is BPPV mostly. The second one, we are thinking of something like, you know, the disturbance of the vestibular system due to various diseases, Meniere's and other things. The third one, we are thinking around the CNS causes. The last one, general medical causes. This is what is called sieving of the vertigo. Now, what are the clues for in the history for the differential diagnosis? Benign, paroxysmal, positional vertigo. This is the maximum covered topic in this lecture because this is the very common thing and easily sort of benign thing and treatable thing also. So here, BPPV, you say to the patient, what is that? I don't know. Benign, so it's not dangerous. Paroxysmal, comes and goes. Few months you have, again you are normal. Positional, related to the position of your head. And then you change positions from sitting to standing or lying down to sitting or rolling in the bed, you get the vertigo. It is benign, paroxysmal, positional, vertigo. BPPV, episodic, true vertigo for few seconds to 1 minute, associated with head or body positional changes, benign and paroxysmal. Now, inner ear disease, sudden onset and vivid memory of the vertigo, hearing loss, ear pressure and tinnitus are related to inner ear disease. Meniere's vertigo loss for hours or days along with vestibular neuronitis also similar features. CNS or cardiac or systemic disease, gradual in onset, patient will not be able to say, I am normal up to this point and from this day I have the giddiness. Whereas these people will be able to pinpoint and say that. So multiple signs are present related to cardiovascular disease and systemic disease. Cerebrovascular diseases like stroke and all sudden in onset, there will be associated neurological deficit and cerebrovascular risk factors also will be present. These are the things in the history that will tell you what type of vertigo it is. Central vertigo, brainstem causes diplopia, autonomic symptoms, nausea, dysarthria, dysphagia, focal weakness, unable to move around, ambulate. This is again telling about the central vertigo. Cerebellar causes dysdiadochokinesia, cerebellar signs, ataxia. Meniere's, hearing loss, ear pressure, tinnitus, progressive disease. Vestibular neuronitis, upper respiratory illness, viral illness, sensory changes also there in the C2 and C3 area, patient recovers. Migraine headaches associated with dizziness. Cerebrovascular disease, sudden onset, neurological deficit and risk factors. These are some of the things in the history and clinical finding will tell us what we are dealing with. The DDs from central and peripheral vertigo is very important. Nystagmus is a very important sign in vertigo and a detailed assessment of the nystagmus is required. Okay, what is nystagmus? Quasi-purposive movements of the eye, which are the movements, sudden jerky movements of the eye, to and fro jerky movements of the eye. Detailed assessment is by the ENG, electron nystagmogram. Spontaneous or gauge-induced or positional in nature, associated with nausea, autonomic symptoms, could be horizontal nystagmus, could be vertical, rotatory, or there could be latency also in getting the nystagmus. FFS, failure of fixation suppression, fatigability by repeated testing have to be elicited. The other vestibular test that we do is caloric testing. What is caloric test? Take water which is 7 degrees cooler or 7 degrees warmer than the body temperature. Not 0 degrees water and 100 degrees water. Patient will never come back to us. So we have to use 7 degrees less 30 degrees, 7 degrees more 44 degrees. This is cold saline, this is warm saline. Don't use distilled water, only use saline here. What we do is inject 1 ml into each ear separately, observe for nystagmus using Frengel's gases. What are Frengel's gases? I will show you next. And then the sort of way to remember that is the COWS, cold, opposite side nystagmus, warm, same side nystagmus. If I inject, let us say, warm saline of 1 ml into my right ear, and the nystagmus will be to the same side. And if I inject the cold, the nystagmus will be to the opposite side. Okay, and absence of this reflex tells there is a vestibular paresis or vestibular paralysis. Cold calorie test, hot calorie test, warm calorie test are normal responses. Absence of those responses is important. An involuntary rhythmic oscillation of the eyes, there will be jerky fast phase followed by a slow return to the starting position. The direction of the nystagmus is always towards the fast phase. Electronystagmogram accurately records it. Horizontal, vertical, rotatory types occurs for 10 to 40 seconds after the head movement. Fatigability indicates a peripheral cause. What is fatigability? You elicit the response as the nystagmus. Again and again you try to do the same movement of the head. You will not get it. That is peripheral. Central, there is no fatigability. This is one way we can differentiate. These are called the Frenzel's glasses. What are they? If the patient wears these are 20 plus diopters. 20 diopters plus lenses are there. So nothing is visible to the patient to fix the gaze. So they will not be able to see anything clearly in front. So they cannot fix their gaze on anything, and you can see the nystagmus very easily in the eyes. Otherwise, the patient will be looking left, right, and everywhere, and you will not be able to look at the nystagmus. There is also computerized video ENG. This is connected to the eye movements are recorded, and on the screen they are projected and then stored for future purposes. Now, vestibulospinal reflexes VSR, vestibulospinal reflex are tandem gait walking. That is, you ask the patient to walk 1 foot before the other on a straight line, and also ask the patient to keep the hands like this, and then if there is a sort of vestibulospinal reflex problem is there, one limb will be drooping. Then Fukuda stepping test. What is this? What we do is there will be a circle of around half a meter. Circle will be there, and within that 0.5 meters, within that circle, he is asked to stand and close the eyes with both the hands on the side, and then start stepping around 50 to 100 steps. With the closed eyes and then the open arms, we should not deviate more than 0.5 meters from that circle, nor we should go change our direction more than 30 degrees if the vestibular apparatus is working well. Whereas in the Fukuda test, with this people are having vestibular problem, they will not be able to keep it to that small circle. They will move out of the circle, or they will deviate to a side more than 30 degrees centigrade, 30 degrees from the position. Okay, Hammett vestibular stress test is, and there will be a soft pad will be there, and a very soft high performance cushioned pad is there. And on that pad, like something like a bed, a patient is asked to stand. Normally, when the surface is not hard, it is very difficult to stand and balance. People who have the sensory component affected in the peripheral thing, they will not be able to stand at all, because whatever little impulses they are getting from the bhumi or the earth, the hot feeling, they will not get it on the soft thing, and they will fall. The motor component is, they stand on that, sensory component is all right. I just hold the patient's shoulder and give, and then ask him to resist my hand pushing the shoulder, and suddenly I release the hand. So patient will not be able to keep the balance and he falls. This is the motor component test. Hyperventilation test also is there. Now, routine test protocol, thorough clinical examination, clinical tests of balance, as described, complete urological examination, blood test, ECG, CV risk factor assessment, cervical spine evaluation, pure tone audiometry, vestibular test as described above, and very rarely MRI, MRA of the vestibulo-basilar territory may be required. So vestibulo-ocular reflex test, I told you about ENG, and also optokinetic nystagmus, and other tests which are a little bit out of the scope of a general practitioner. Cold calorie tests also I told you. Positional tests I told you. Most important is the IMPAI position test, which I will show you in detail, which is very important. Every general practitioner must know how to do that. Computerized dynamic postulography not routinely done. Rotating chair test and sinusoidal horn acceleration. These are all very specialized tests. Oscillopsia is as though the world is oscillating. Before that, I'll show you a video of that also. Rotatory test chair is, the patient is sat in the chair, and the chair rotates at different speeds, and we'll see whether they get the vertigo in the prescribed time. And then we know that the 4 main categories, BPPV is 50% of the vertigo is BPPV, 25% is syncope, 15% is ataxia, and 10% is psychogenic. The balance disorders are roughly, this is the category. So BPPV is so important. We would like to know more about that. Is it central? Is it peripheral? Peripheral means it is the vestibular apparatus is at fault. Central means something related to the brain, brainstem, circulation, nerves, blood quality, and all that is central. Now, coming to the peripheral vertigo, BPPV stands out very prominently. This is the major cause. Meniere's disease, autoimmune neuronitis, autotoxins, labyrinthitis, vestibular neuronitis are the other causes. Now, you see here the BPP video. The doctor is putting the IMPAI test there, and you can see once the head is lowered, you're able to, after latency of that, you're able to see the nystagmus coming up. After 10-second latency, the nystagmus starts. And always the faster component towards which side it is going, that is the side of the nystagmus. And we have to ask the patient to keep the eyes open throughout the test. Then only we will be able to observe the nystagmus. I'll show you step by step. There is a Meniere's attack also. Meniere's occurs in attacks, and these attacks are, you can see the Meniere attack, how it looks like.
Can you see anything in there at all?
Black, and on the sides I can see little white.
There will be watering, there will be chemosis, there will be nystagmus, and there will be hearing loss, there will be ear pressure will be there, and it is a progressive disorder. Meniere's disease is a progressive disorder. Tinnitus will be there. Now this is oscillopsia.
Oscillopsia, the illusion that the environment is moving when we move our heads, is the characteristic
Very nice, no?
visual symptom when vestibular
Kunjilla
function
ukkandhu
is lost.
mele kila vara madiri irukku nalla.
Oscillopsia often occurs
But
when
unfortunately,
riding
this
a
is
car,
no good
especially
as a
when the
patient.
road is
When you are
bumpy.
driving,
This
if
can
things
make
are coming
reading
like that,
street
you can
signs
imagine
difficult
what
unless
sort
the
of
car
things we can do
slows or
on the in the
stops.
driving. Oscillopsia is a
also
problem.
occurs when
So
running,
ocular
walking
reflexes
quickly.
are at fault. Now, when you come to the central causes, just like in the peripheral causes, the BPPV is the main important thing. Here, migraine is the most important thing for the central causes. Meniere's, CP angle tumors, VBI, multiple sclerosis, and cervical vertigo are the other causes. Now, cervical vertigo, you see the video. This is due to the compression of the spinal cord, either by the cervical spondylosis or by tumor or by any other pathology of the cervical cord. Head put to the left side. Now after a latency, they start developing the nystagmus. So that's how it is brought. Now, how do I differentiate central from peripheral? Peripheral vertigo, rotatory type of nystagmus, 30 to 40-second latency, fatigability plus, habituation plus, intensity severe, reproducibility variable, positional nature, cautious gait people will have, hearing may be decreased, tinnitus may be there. Central, horizontal or vertical type of nystagmus, immediately it occurs, no latency, no fatigability, no habituation, mild intensity, good reproducibility, hyperactive view or reflexes. People will be walking with wide base to avoid falls. This is a central type of vertigo. Brainstem or CNS are at fault. This table will tell you it's central or peripheral. Among the central, the commonest is migraine, and among the peripheral, the commonest is BPPV. So benign positional vertigo, episodic vertigo may occur with head movements, rolling over in the bed, lying down, sitting up, leaning forward, turning the head to the horizontal plane, any one of them. Symptoms of BPPV are worse in the morning, nausea may be there but no vomiting, history of head trauma may be present, episodes of vertigo and BPP last for few seconds, vestibular neuronitis and labyrinthitis also. They will be in hours to days. Pathophysiology, calcium carbonate particles, I told you, no, the otoliths or autoconia, they are there, they are normally attached to the hair cells on the membrane inside the utricle and saccule. They are not supposed to go into the semicircular canal. The utricle is connected to the three semicircular canals. These otoliths may become displaced from the utricle and saccule by aging, by trauma, by labyrinthine disease, and they enter the semicircular canal. Once they enter the semicircular canal, these small microliths or otoliths, they stimulate the cells in the canal and cause vertigo. Normally, these otoconia are supposed to stimulate only when they are in the utricle and the saccule. But here they are detached from this place and they are getting into the canal and producing. Very common due to age. As I told you, 10% of people above 55 do have vertigo. You can see here, and this is an animated GIF. See, when the person is lying down 105 degrees position, displaced autoconia. The autoconia are here, they are not supposed to enter the canal, but you know, these are the autoconia and these are the microlegs, and they enter into the canals from the utricle when the position is tilted. Okay, that is the cause for the BPPV. Now, Dix-Hallpike test in BPPV is very important test. I'll show you step by step how it is done. So see this video first and then we go step by step. Turn the patient's head to one side, make the patient lie down, support with your arms, and then quickly turn the head to the opposite side and then get the patient up. Now, so Epellis maneuver, this is again the maneuver for the Hallpike test, and I will show you step by step. So first thing is, patient is seated on a couch. The doctor should be available always. Suddenly they may find, you have to warn the patient that they might develop giddiness, they might vomit also, and be prepared for that. Then next step is, you hold the patient's head like that, and then towards you turn the head like that. Of course, you turn your face away so that you won't breathe into your face and mouth. And then you suddenly lower the head, and the head should be away from the couch like this. It should be falling. So this I always do in my clinic, this sort of Epellis test to find out whether it is BPPV or a very simple test any one of you can do if you go by step. This third step. The fourth step is, we have lowered into such an extent that patient is able, as far as his neck permits, without injuring the neck, we will of course support the head with our hand so that there is no pillow there. We should not leave the head hanging down. Then what you do is, you turn the head to right side first. So we have turned the head to the right side a bit. Patient is still laying flat and we have not asked him to turn around. And then you ask the patient to turn to the right side onto the shoulder, right shoulder, and the patient turns now with the head still in the same position. Then you turn the head further 90 degrees as the patient is looking down onto the floor, but the still patient is on the right lateral position. Then what you do, you hold him in that position for 30 seconds to 1 minute and see whether he develops symptoms of giddiness. And then you slowly get him up with the head supported by both of your hands, and with the help of his hands he gets up and sits. Then you stand in front of him, still the head is held with the hands, and now bend the head forward, the next step. And then during this procedure he should develop, if he develops giddiness, then that is positive for BPPV. So you just go through this sort of presentation. I'll share you can understand how it is. Epellis maneuver, again I'm showing you in the video here. This is an animated video. You see, getting them down, turning the head to one side. This time she turned to the left side and rolled the patient to the left side and asked the patient to look down further and then slowly get up and then watch for the nystagmus and giddiness. Patient should be keeping the eyes open. Treatment. Okay, so far so good. We have to use the treatment very judiciously. Treatment depends of course on the cause. Branded Daroff's exercises for BPPV, what are they? I will circulate to Dr. Kailash. He will give you a copy of that. Very simple exercises. Most of my patients are better off with the exercises than with the drugs. Meniere's disease, reduction in the salt because there is a high drops or sort of swelling of the utricle and the saccule and the semicircular canals, reduce salt intake and fluid intake, use diuretics, particularly Diamox or acetazolamide for migraine prophylaxis, using migraine drugs like Sibelium and other things, drug treatment to control the acute symptoms, steroids for acute labyrinthitis and vestibular neuronitis. They do a lot of good. Don't be afraid to treat with steroids if it is acute labyrinthitis or vestibular neuronitis of viral origin. Stop autotoxic drugs. Look for postural hypotension. TTG. What is TTG? Transtympanic gentamicin. Gentamicin is autotoxic. You inject the gentamicin into the middle ear transtympanically to paralyze the vestibular apparatus so that there is no disturbance. Or labyrinthectomy for refractory Meniere's disease. Vestibular rehabilitation exercises, the branded BD exercises are really good for BPPV. Now, This is the description about those exercises. I will circulate the pamphlet. It is better understood with the diagrams than with the theory. Now, what are the drugs that I can give? This is the question which all of you are asking. I am very sure all of you are prescribing. The moment patient says DG or GID, immediately you write Stugeron or Vertigen. Vertin or Stugeron is readily on your paper. Please don't do that. Those are not the drugs of choice. The best drug of choice is meclizine, which is an antiemetic, anticholinergic. It is available as an antivert. That is the drug of choice for vertigo. Benzodiazepines, particularly lorazepam, available as Etivan, Lorpos 2 milligrams, or clonazepam, available as Clonatril, or G or any other brand that you want to use, the next best drug. Antihistamine type 1 promethazine, which you would have used as in pediatrics, you know very much. The Finergon 25 milligram tablets, very effective. Most of the patients, I put them on Finergon. And antiemetic and antihistamines, dimenhydramine or Dramamine, which you use it for motion sickness or seasickness, is very effective here also. Anticholinergic like scopolamine, the problem is side effects, so use scopolamine. Isopropyl patch is used in anticholinergics, but the best drug could be meclizine, lorazepam, and then promethazine or dimenhydramine. Whereas here cinnarizine and beta histidine. Cinnarizine is a calcium channel blocker available as Stugeron and many other brands in our country. 75 milligrams also is available for us, and beta histidine is available as 8, 16 and 24 strength. And these are used very left and right by all of us, but then they are not approved in many countries, including the United States. FDA approval is not there for both the drugs. This was very shortly approved for 5 years, then they have removed the approval here. They only treat in that country with meclizine or promethazine or benzodiazepines. They don't use Stugeron or Vertin. Now it is up to you to decide. Another important word of caution I want to leave you here. These are not for acute treatment. Why? They take time to act, 1 to 2 weeks for the action to build up. Particularly cinnarizine. Only after 2 weeks the effect starts coming. Beta histidine slightly better. After 5-6 days you can start the improvement, but not for acute disease. Somebody is having acute vertigo, don't prescribe cinnarizine and wait something to happen. He recovers because he is benign paroxysmal vertigo, and it is God-given recovery and not our credit. Now, what are autotoxic drugs? Aminoglycoside antibiotics like gentamicin, amikacin, netilmicin, kanamycin, streptomycin. We know many of the patients who are treated for tuberculosis with streptomycin containing regimens. They ended in permanent deafness and permanent damage to the vestibular apparatus. Quinine and derivatives, chloroquine can be a potential hazard for the ear. So we have to be very careful. Furosemide in larger doses, long-term use, bumetidine, ethacranic acid, all are loop diuretics. They have a potential to cause ototoxicity. Anti-cancer drugs like carboplastin, cisplatin, vincristine. What happened the other day? We had a patient who developed, right paranasal sinus, fungal infection with aspergillus, and the patient was treated with amphotericin. He ended up in ototoxicity and also renal toxicity. We have to be careful with drugs like that. Aspirin and NSAIDs can also, in large doses, can cause ototoxicity. Ototoxic ear drops. Don't prescribe gentamicin ear drops left and right. Gentamicin could be ototoxic. In fact, you have seen trans-tympanic gentamicin as a treatment modality. So never try to use gentamicin ear drops. Gentamicin eye drops are okay. Gentamicin ear drops are not good. So better you use, either Norflox ear drops or Genflox ear drops or Moxiflox ear drops or something other than that. So these are the various things I wanted to share with you. The disease, the pattern of the disease, the different types of vertigos, and also the sort of classification, the diagnostic tests, and of course the management, drug management, ototoxic drug. Maybe at this point, I would like to stop my talk and just wait for a couple of questions if you have, and then thank you all very much.
Till now,
Thank you, sir. Thank you, sir.
very easy.
Thank you for your excellent talk.
Person comes, I used to give Vertin and get rid of it. Now I'm
Most of us we use.
Yeah, that's what you should not do, my dear. The idea of this presentation is Vertin and Synergine are not the drugs of choice.
Widely used drugs by all of us.
Only when the patient is having chronic vertigo, if he is not responding to promethazine or meclizine, you can put him on Stugeron for a long-term effect. In our country, it is approved. In US, they don't use it.
We have few questions, I think, so Dr. Shivasamy, Soumya.
Don't meclizine, promethazine, etc. cause drowsiness. In the doses that you would like to use, for example, Phenergan also in promethazine causes drowsiness, but 25 milligrams is a very well tolerated dose. It depends on, you can start with a smaller dose, 12.5, and build it up. And preferably you give night 25 milligrams, morning 12.5.
Dr. Sharma, till now, vertigo was not a problem for me at all. Now I'm scared to treat vertigo because so many things are involved.
Yeah. Vertigo itself is a vertiginous subject.
You have showed us some few
Dr.
videos.
Sharma, I was in fact practicing even last year. I was utilizing Stemetil MD, and I used to give Stemetil MD sublingual tablets, and the patient used to recover, and they tell I'm doing better. Along with Vertin, 18 milligrams, 16 milligrams, they are feeling better.
Stemetil is prochlorperazine.
Yeah.
Prochlorperazine is very good. It is also a good antiemetic vestibular sedative. You can use that effectively. I do use Stemetil in some refractory cases. But your idea of combining Vertin 16 milligrams is debatable. It is not as per the book. We are doing it, several things.
Okay, and do you advise them to take plenty of fluids or without salt?
Salt should be restricted because there will be high drops of the semicircular canals and saccule, particularly in meniers. So advise them, if it is peripheral vertigo, they must reduce the salt intake.
Okay, going to question number 2. Can vertigo lead to stroke?
What is that? Can vertigo lead to stroke? Yes, I told you. Vertigo is central causes are there. Suppose the central cause is vertebrobasilar insufficiency. The brainstem is not supplied blood. Naturally, you will have a cerebellar stroke, isn't it? Vertigo is not. It is a general word. Somebody is saying fever. I don't know what is fever. If you tell me typhoid fever, I know. I don't know what is fever. There is no one answer for vertigo. Is it central vertigo? Is it peripheral vertigo? Is it autological vertigo? Is it neurological vertigo? Is it anemia? The first thing I would exclude is gross anemia in Indians. Anemia and visceral hypotension due to hypertensive drugs are very notorious to cause dizziness.
Vertigo itself, we can have vertigo clinic itself, we can start, I think. So much.
There are vertigo clinics. In fact, we have a vertigo clinic in Manipal Hospital here. You can also start just like asthma clinic. You can open a vertigo clinic, and what all you require is one general physician, good general physician, and if necessary, a neurology referral and an otological referral. That's all is required. Tests are very simple. They are not very expensive. We don't require an MRI all the time.
You have narrated so many causes of vertigo, and I think now it's very difficult to diagnose vertigo.
So very simple, divide them into central and peripheral. Among the peripheral, that is the apparatus is at fault. Commonest is BPPV, which is benign, paroxysmal, positional vertigo. It goes on its own, and you take the.
The problem is at this age to remember all the causes. When you're probably a medical student, we would remember. But at 70 years, to remember so many causes of vertigo for a professional.
Not all are common. Not all are very common. Meniere's disease, and then the vestibular neuronitis, then BPPV, cervical spondylosis, and rarer causes anemia, postal hypotension, autotoxic drugs. 5 or 6.
Good.
But the EPILATE test is useful, no? In the clinic, if you can do EPILATE test, you.
Yes, you can do it. I'll give you the pamphlet. There are 13 steps are there. Go. You have to do it. If somebody comes with vertigo, don't send him without doing EPILATE test. If you do that, you will be missing a very simple diagnosis of BPPV and then putting him for MRI, this, that, and all sorts of neurological consultations. Absolutely not required. If EPILATE is positive, you are safe and patient is safe. You don't require to refer anywhere.
Somebody has asked
Any other questions?
Pardon?
Any questions?
Ibelium, is it effective?
Sibelium, the migraine is
Migraine.
certainly yes. Sibelium is used in migraine, as all of you know, and migraine, 10% of people with migraine do have vertigo. It is definitely helpful.
Soumya, is Dr. Shivasamy, you have answered his question? He is raising his hand.
One moment, I'll just go one by one. Next question is role of MRI angiogram in treating vertigo and role of steroids in vertigo.
The first question I answer later, and the second question I answer first. Steroids are the treatment of choice if this is vestibular neuronitis or labyrinthitis due to viral etiology. Just like we use steroids now in COVID, severe COVID, and for a short exposure of 5 to 7 days of parenteral or oral steroid will definitely relieve the inflammation and make them become better faster without residual damage. So steroids are indicated in vestibular neuronitis and vestibular labyrinthitis. Second, the first question is MRI and MRA not required. Not routinely, unless you are suspecting basilar artery migraine or basilar artery circulatory problems, or if you are suspecting intracranial problems. You must have some neurological defect, some neurological evidence to say that you require an MRI. For every vertigo, we don't do an MRI. Epilim maneuver you do. It's a very simple one. And then do this few tests. I told you, I'll show you how to do a couple of tests. I'll just move a little. Maybe you will be able to see me. Okay, here. So I'm now tandem walk. That is, I'm keeping one foot to another and asking the patient to walk with eyes open and then eyes closed. This is one thing. The other thing is ask the patient to stretch the arms, draw a circle around you, and ask him to close his eyes and step there. 100 steps. Normally, we should be within that circle. People with the vestibular problems, they deviate towards 30 degrees or they come out of the area. So this is number one. The other important thing is ask the patient to ataxia. If you want to bring out, ask them to lift the hands like this, and then if there is a peripheral disturbance due to sensory problem, it will be drooping on the side of it. This is another common thing. So, of course, dysdiadochokinesia and other things, and cerebellar thing, looking for nystagmus. Never fail to look for nystagmus. Ask them to open the specs and then ask them to look at a particular fixed point and then to the left and to the right. Okay, you can bring out the nystagmus by doing the FE test. Calorie tests are also very simple, but usually not done in our clinics. Usually there is a separate labs only will do very simple test. Only thing is warm saline and cold saline and COWS, cold to the opposite side, warm to the same side.
Next question, what is your choice of steroid?
I told you already, steroids I give only when there is vestibular neuronitis, not for BPPV.
Your choice is
What choice?
Prednisolone. Prednisolone 30 to 40 milligrams. 60 milligrams is the upper dose. Of course, every week you reduce 5 milligrams. And in this case, you don't have to give long. You have to stop it after 5 or 7 days. You don't even require tapering. If you use, remember always is another thing. Steroid means tapering. You give 3 days again, tap not required. If you give more than 10 days only, the tapering question will come. A short burst of steroid, no tapering is required. Abruptly you can stop. Nothing happens to the adrenal axis.
Using these headphones often, can it damage the ear and cause vertigo?
Lot of children. There, particularly the magnetic radiation that comes out of the cell phones is going to do that. That is why always it is better to use a sort of earphones rather than directly putting the phone for longer times. Today, if we start chatting with Kailash, let us say I started a call, it will end only after 1 hour. That is the way we are using the phone, as though it is the end and all of life. Phone is for just conveying the message, and ask them to text the message rather than calling. As far as possible, use the text message.
No, but if you use a Bluetooth, then the radiation is much less.
They are not dangerous because the radiation is far away from you.
Yeah.
Bluetooth doesn't radiate.
Thank you, sir. Thank you so much.
Very nice.
Thanks, Dr. Sharma. Thanks a lot.
Thank you.
Questions are- we can go to the next talk.
Every week we will be every month we'll be having the session around the same time.
Yes.
And I would suggest whether you can go for syncope, which is a very common subject and allied subject to this. How to differentiate this and how to treat syncope also people must be knowing. Probably that could be the next topic.
Yeah.
After
First,
that, we will
first
go-
Sunday of
We
next
can have
month.
it in the month of November.
First Sunday of
We
next
can
month.
have it in the month of November.
November we can have syncope, and then we can later on we can have migraine also, like that very common clinical disorder.
Migraine will be better, sir. Migraine is a very common topic.
Migraine and syncope too. Syncope also. Majority of the youngsters
Yes,
do
sir.
syncope. There are cardiogenic, neurogenic, and then peripheral, central. So many things are there in that also to learn. And what is the practical approach? I hope you people got some practical guidance as far as vertigo is concerned by my talk today. If that is achieved, and think the objective is fulfilled.
Yes, sir. Definitely. Yeah.
I am
November-
happy to
November we
get back
can
to my CME group through Dr. Kailash. I thank him and also thank my friend Dr. Girija madam for bringing me over here again.